Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Anny Su from New York, United States. Dr. Su is an orthopedic surgeon specializing in foot and ankle surgery at the Westchester Medical Center, New York State. She's also a clinical assistant professor of orthopedic surgery at the New York Medical College. Dr. Su did her undergraduate studies at Stanford University and received a master's degree in mechanical engineering. She then went to Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University for her medical studies. She then completed her orthopedic surgery residency at the Columbia University and a foot and ankle fellowship at the New England Baptist Hospital. Dr. Su is a member of the American Orthopaedic Foot and Ankle Society. He's a candidate member for the American Academy of Orthopedic Surgeons, the Ruth Jackson Orthopedic Society, and the Medical Society of the State of New York. Her clinical interests include foot and ankle reconstruction, total ankle replacement, ankle arthroscopy, minimally invasive foot and ankle surgery, and lower extremity trauma. So today, it's my great honor to introduce you to Dr. Anny Su from New York, United States. Over to you, Anny.
All right, thank you for the introduction. So today I'll be talking about CavoVarus foot deformity correction. And to start off with a little bit of background, the definition of being a pes cavus deformity is really for Meary's angle with with an apex dorsal angulation. But this actually having an elevated Meary's angle is commonly found in roughly about 24% of the population. And here's a clinical picture. You can see it's not just the cavus portion, but also the hindfoot is indeed a very notable varus alignment as well. So there's several etiology that can really cause someone to have CavoVarus deformity. And a large portion of this is a neurogenic etiology. So this can include polio, stroke, Charcot-Marie-Tooth, cerebral palsy, Friedreich's ataxia, spinal cord lesion, and SMA. For children, this is commonly a congenital and noted with clubfoot and also arthrogryposis. For adult patients that does not have any underlying neurogenic causes, this can be an aftermath of some trauma, including burns, compartment syndromes, crush injuries, and very commonly with talus fracture malunion, as well as a peroneal nerve injury or peroneal tendon insufficiency. So the patients usually are used to having these deformities, and their complaint coming to the office is usually of the associated pathologies. So they complain of metatarsalgia, sesamoiditis, and commonly because they have been overloading their lateral ankle, they complain that their ankle is unstable, is rolling in, and they develop pain along the peroneal tendon. Patients also sometimes have fifth metatarsal stress fractures from overloading the lateral border of the foot, and also form these plantar fifth metatarsal ulcerations as well. So if this continues for a prolonged period of time, patients can eventually also develop medial compartment knee arthritis. So just breaking this down into four main things, why does CavoVarus happen, the biomechanics? The peroneal longus is very hyperactive. So what it does is essentially plantar flex down your first metatarsal and alters a normal foot tribot weight-bearing effect. So with the first ring now plantar flex, your subtalar joint is now being pulled into a varus, and then it locks into a fixed varus hindfoot deformity. So you can see here that the clinical exam, you can see what was termed by Manoli back in 1993 as the peekaboo heel sign, where if you look at the patient from the front, you can see the heels peeking out medially. And if you go behind the patient to look at the hindfoot alignment, sometimes you have to be aware that their alignment sometimes can appear to be neutral, but their subtalar joint is actually everted to give that a neutral appearance. The Coleman block test is a tried and true, very old test, but very helpful because it helps us differentiate the forefoot driven flexible deformity, where correcting the forefoot can help neutralize the hindfoot alignment, as you see here on this middle image, versus a very fixed deformity where the hindfoot remains locked in despite having a block to correct the forefoot. So the clinically forefoot pathologies, you also see patients with metatarsal adductus as well as forefoot valgus. So in addition to clinical assessment, we also have x-rays to help us to further diagnose the patient. And I initially like to break them down to looking at the hind foot first and then looking at the midfoot. So the hind foot, looking at the lateral x-ray for CavoVarus deformity, you have an increased calcaneus pitch. And looking at the AP, if you focus strictly over on the calcaneus and the talus, there's a decreased talocalcaneal angulation. And lastly, and perhaps the most obvious sign is to look at the Harris axial view. And you can see that the hindfoot, measuring in the amount of angulation of the hindfoot with respect to the axis of the tibial shaft. And you can measure how much varus angulation you have from this view. Now, going back to our lateral view again, you also want to focus on the midfoot as well. So the height of the navicular can be noted to be very elevated with a high arch. And this can also be assessed with looking at the distance between the medial cuneiform. If you draw a line parallel to the floor, and also comparing that to the one that touches the fifth metatarsal and measure the distance, which is an assessment of how elevated the arch of the midfoot is and how unbalanced the medial lateral side of the forefoot is. The talonavicular joint is never quite normal. It always have a slightly sublux appearance, so that beware of those peritalar abnormalities noted on your AP X-ray. So with all good orthopedic treatments, as a surgeon, we don't jump right to surgery. So we try conservative treatment first with gastroc stretching. And for flexible deformities, sometimes they respond quite well to orthotics that are especially designed to address the deformity. So specifically, your orthotic need to have a lateral hindfoot post and very low arch that helps counter the hindfoot varus deformity. And the first metatarsal head usually is kind of shallowed out, so there's a depression to allow for the plantar flex first ray. So when all else fails, the next thing we think about is how can we fix our patient and help them surgically? And there are quite a lot of factors to think about for preoperative planning. So I'll go through them one by one, but these are very important because this is a very complex three-dimensional correction, and it's often easy to miss one small portion or overlook one aspect of the correction. So first, I spend a while before talking about the Coleman block test, because this truly kind of delineates your pathway of which how much bony work versus soft tissue work you really should do. So not just in foot and ankle, but in general, when you have a flexible deformity, you can focus more on your tendon transfer, whereas a very rigid and fixed deformity, you want to be a little bit more aggressive to have a more powerful osteotomy correction or an arthrodesis correction. The second thing to think about is are there any arthritic changes involved? So I start with the tibial talar joint and look at the joint congruity to assess for any talar tilt. And with the hindfoot, sometimes it's difficult to assess, so I would obtain CT to see if there's any other pantalar joint arthritis involved. So if there is arthritic changes, deformity is rigid, and patient is symptomatic, then I would jump to an arthrodesis to address those arthritic joints. So that could be either in the form of subtalar fusion for subtalar arthritis, or triple arthrodesis if you also have degenerative changes in the talonavicular joint and calcaneocuboid joint. The third question is Achilles tendon tight? Do you have any equinus contracture? And I would say about 99% of the time you do. And because if you think about the heel being in a varus position, once you want to straighten out into a neutral alignment, you inevitably have to have increased length in your Achilles tendon construct. So depending on how much of the equinus contracture you have, you can either address this with gastrocnemius recession versus Achilles lengthening. And last but not least, you don't want to overlook any concurrent problem, such as lateral ankle instability, because these people presumably have had developed these deformities for quite some time, especially for the chronic worsening deformities. And they sometimes wear out their lateral ligament, and that can be addressed with a rostrum. So I think the most important pearl and pitfall at this point, before even going into surgery, is to miss the neurologic workup. Because if your patient has an underlying neurologic cause for deformity, this can potentially be a progressive muscle imbalance. So if you do not realize this and rely only on soft tissue correction, the patient could redevelop the cavovarus deformity. So the next part, I'll talk about the arsenal things we can use a little bit more in depth before I go on to sort of my own algorithm and what I do in the OR. So the soft tissue correction for equinus contracture, the main workhorse you think about are three things: gastroc recession, percutaneous Achilles tendon lengthening, and posterior release for the very extreme cases. So when your range of motion is limited, but not extensively limited, and you can use the silver skull test to identify you have gastroc tightness, then a gastrocnemius recession can be done. And when you have a greater equinus contracture involving the Achilles, then the traditional teaching is to do a percutaneous or an open Achilles tendon lengthening. However, keep in mind that sometimes you can have extensive amount of stiffness where your ankle does not dorsiflex beyond neutral, but the heel cord doesn't feel tight. And I think in this particular situation, it happens with residual clubfoot deformities that was previously corrected or post-traumatic deformities. They can develop very extensive amount of posterior capsule scarring. So a posterior capsule release is needed, and sometimes even an ankle joint debridement is needed as well. The other things to keep in mind for soft tissue correction is breaking down the CavoVarus deformity into hindfoot and forefoot portion. So the hindfoot portion, I think about the CavoVarus foot being driven by a very strong inverter and very weak everters. So for me, I focus more on the weak inverters because your peroneus longus can be transferred to the brevis to strengthen your weakened foot everters to help bring the foot out from the CavoVarus deformity. Similarly, you can also address things immediately by weakening your posterior tibialis tendon, either through lengthening or transferring it dorsally, which I'll talk about a little bit more later. But that weakens the strong inverter to help balance the foot out more. For very severe neurogenic cases and for congenital cases, oftentimes you have very severe claw-toe deformity for your forefoot, and this can be addressed with Jones procedure. And for the lesser toes, a short flexor releases may be performed. Now, moving on to more severe rigid deformities, we have to use something that is a little bit more powerful in addition to soft tissue correction. So for mild to moderate fixed deformities, the main workhorse would be first metatarsal dorsiflexion osteotomy to elevate that plantar flex first ray, and also to do a calcaneal osteotomy, which can be done in different flavors with lateral calcaneal slide or Dwyer's closing wedge osteotomy. Sometimes even with these two combined, this is simply not enough to really correct a severe deformity, and a lateral column shortening may also be performed over the cuboid or the calcaneal cuboid joint. So for severe deformities, other things to think about for post-traumatic CavoVarus deformities, the axis of rotation is really from Taylor's malunion, and you can argue that the strongest and the most effective correction is ad cora. So a Taylor neck osteotomy can correct the deformities caused by very severe Taylor malunion. For very high arch, extensive, severe CavoVarus deformities, Midfoot dorsal osteotomy wedges can also be performed as well. This is a much larger correction and a much prolonged recovery process, but it again focuses on correcting things from their center of rotation. Arthrodesis portion I had previously mentioned, when you have arthritis in the hindfoot joint and they're symptomatic, instead of doing osteotomies, the overall alignment can be correct through the joint while you are doing your arthrodesis. I want to emphasize that before we dive into the foot, it's always important to get a standing ankle x-ray to see if you have any ankle varus deformity, because everything is all connected. So if your ankle is in varus, your whole foot will appear to be in severe varus deformity, and you must consider a supramalleolar osteotomy with a lateral closing wedge first before you can truly correct the residual malalignment of the foot. So next I'll talk about my OR setup and some of the things I think about, some of the workhorse steps that I talked about before that I use and don't use, and as well as some of the technical challenges that I think it's important to keep in mind as you go through. So a very typical foot and ankle setup in the OR is to have the patient be supine on the bed, the feet at the end of the bed. And a bump underneath the hip to help correct for the external rotation of the lower extremity. I prep everything up high to the knee. There's a tourniquet on the thigh. And depending on what is planned, I typically try to have a minimally invasive surgical instrumentation, the MIS high-speed burr, to make my osteotomy cuts. You can also do everything with a sagittal open cut as well. And I also use, for gastric releases, I would use an endoscopic release as well, and those would be using as your standard knee arthroscopic instrumentation, and have a mini C-arm in the room so I can check for overall alignment as you correct each step of the way. I typically prefer to do bony work first, as I was always taught that your structural change protects your soft tissue correction. However, the very first thing that is typically done is the Achilles tendon pathology to address this. And that is primarily because this minimizes the deforming force and allows you to have easier calcaneal osteotomy and heel shift. So, so the first step for me for a CavoVarus deformity is to either do it as gastric recession or to do a percutaneous Achilles tendon lengthening. So you can see this upper right picture. This is the standard mini open incision I would make for a gastric meniscus recession. If I have the instrumentation for a knee arthroscope setup, then I would use an endoscopic procedure where I have a sheath that slides right underneath the gastric fascia, and you can visualize. These pictures are from Dr. Giovanni's paper. Talking about surgical techniques doing endoscopic gastric recession, where you can visually see where you're cutting with a small hook blade and avoid the disrupting the sural nerve. So once the Achilles tendon lengthening is done or gastric recession is done, next we can go back to focusing on bony correction. So I start from hindfoot first with the calcaneal osteotomy. And I include Doyer osteotomy as the first thing to go over. So Doyer osteotomy is very popular in the pediatric population or amongst our pediatric colleagues. And what it is taking out a lateral wedge to correct the overall heel position. So you can see here this pink triangular slice, you're resecting a lateral wedge and then swinging the remaining calcaneus over into a physiologic valgus position. And after the resection of the bone, you simply have to dorsiflex the foot and this will close down. And then you can fix this either with screws or pins from the calcaneus. This is widely done in children, but in recent years have not been so popular for adult foot and ankle surgeons, primarily because this weakens the moment arm of the Achilles, and adults do not accommodate for this change as easily as children do. So the preferred calcaneal osteotomy at least for me, is for a lateral displaced calcaneal osteotomy. And this can be done open with a sagittal saw, or it can be done with a small MIS high-speed burr, where through a small poke hole, the calcaneus can be sort of schematically divided into 4 quadrants in your head, and the high-speed burr can be trimming away the calcaneus to create the cut. But no matter how you do your cut, you essentially have to fix it still. So you would shift this calcaneus laterally. And for me, sometimes if the quietness is severe enough, I sometimes shift it a little bit superiorly as well, and before placing my calcaneal screw for fixation. One of the technical challenges and pearls here is that almost always it's easy to place your screw to a lateral because you are holding the heel with one hand in a correction, and the tendency is to aim the screw in the center of the heel. We have to remember you have to angle it slightly medially because you can come out distally with your lateral shift. This can be prevented again with adequate amount of intraoperative imaging to confirm your alignment. The next part of the procedure, I typically go to the next boning work, which would be addressing the first metatarsal plantar flexion. So in order to correct the plantar flexion, essentially, it sounds very straightforward. We are elevating and dorsiflexing the first ray. So a dorsal incision is made over the proximal first metatarsal, and after retracting the extensors laterally, then you can dissect down onto the bone, do your periosteal dissection, measure approximately about 1 centimeters distal from the tarsal metatarsal joint. And this can vary based on your choice of fixation plates versus screws. And a dorsal wedge is removed to elevate the first ray, and you can confirm checking a weight-bearing or simulated weight-bearing positioning in the OR if it's now an even correction. Now, this is a very small bone and sounds very easy, but there are a lot of things that can go wrong. Think about hallux valgus and first metatarsal alignment. So subtle changes sometimes can have a big effect downstream for the patient. So you do not want to change the rotation or shorten the first metatarsal too much with your dorsiflexion osteotomy. And the way to really minimize or prevent these from happening is to ensure that your cut is exactly perpendicular to the shaft. So you're not creating new angles and changing your first metatarsal in a different axis. I typically do my first cut all the 90 degrees, 90% almost all the way through, leaving a plantar hinge. And then I go about 3 or 4 millimeters distally to create a second cut that's aiming toward the first cut, so you can close it down like a book, and it won't you won't be changing the rotation too much because you have an intact plantar hinge to help you with the correction. The other thing here is to notice is that it is common to undercorrect for the first underperform your dorsiflexion osteotomy. You will see this with my own personal examples later. It's very easy to think that your correction is enough when actually more can be done. And the way to really check that is to take a flat surface. So sometimes take the instrumentation tray, a clear radiolucent surface, to pretend and press down on the foot so you can get a better idea of what a weight-bearing x-ray is for your correction. And that way it can give you a more real-life correction of correlation of how overcorrected or undercorrected you are. Essentially, overcorrection is a very rare thing to do because the wedge would have to be extremely large. So at this point, I went back to soft tissue here because usually by the time after calcaneal osteotomy and first metatarsal osteotomy, the overall alignment of the foot would be more or less within the ballpark of an acceptable range. If that is not true for a very severe deformity, you would need to think about adding a lateral column shortening. Although there's significant amount of papers written on lateral column shortening, it's also been proven that you are trading in these subtle change with significant amount of stiffness for patients. So I try to avoid lateral column shortening if I can, but it is definitely a useful tool if your bony correction is undercorrected. Going back now to the hind foot again, your peroneus longus can be transferred to the brevis to help strengthen your everters. If you are doing an open calcaneal osteotomy, you can use the same incision. And one incision you'll make is basically cheating in between the peroneus and the calcaneus, so making an incision that's parallel to the peroneus longus, but slightly inferior. And that way you can address your calcaneus and your peroneus tendon here. You can see the superficial peroneal retinaculum that is intact. And this portion can be done by keeping the retinaculum intact, but sometimes you could see peroneal tendon pathology and need to really have better sense of evaluating this. So at times I would peel off the superior peroneal retinaculum from the posterior part of the fibula. And to do my tendinous work to really assess the peroneus longus, remove the degenerative portion and suture it back, reapproximating into the brevis with O non-resorbable suture. I will repair the superficial peroneal retinaculum with suture tech back to the fibula if I did end up peeling it off. It's important here to point out that this repair over here can be a little bit bulky, so it's important to test it before you close your wound to ensure that there's no tightness or impingement as it travels underneath the retinaculum. So part 5 here I wrote plus and minus partial plantar fasciotomy because this is very commonly written about and is certainly a test to answer for a lot of standardized exams. But this is not something that is done very commonly or with a light heart, I should say, because it is a very risky procedure to be done, and it can have potentially very negative complications and outcome. So partial plantar fasciotomy can help lower, correct your high arch deformity after you've done all of the previous mentioned bony work and soft tissue releases. It can be done open or can be done endoscopically. Essentially, you need to have an incision that's parallel to the plantar heel, and you can identify the medial border and transect about 1 centimeter from the origin of the calcaneus. However, the medial calcaneal branch of the tibial nerve is really directly in your pathway. It's very hard to avoid them, and it's also easy to affect the intrinsic muscle in the plantar compartment of the foot with this incision. And the worst complication that can happen is that patients can eventually have very weakened plantar fascia, develop plantar fascia rupture, and which can be progressively followed by arch collapse. So because of this is not, in my book, I would have to have a very severe deformity to contemplate adding this onto my to-do list in the OR. Jones procedure is commonly done in children or in patients with very severe neurogenic CavoVarus deformity. The great toe has this clawed deformity, which you can see on these two clinical pictures here. So essentially, you can make a transverse incision over the interphalangeal joint, excise the EHL tendon, your arthrotomy, then go in and prepare the surface, curate out the cartilage, drill the surfaces to fenestrate the bone before using a K-wire to pin across the IP joint. And I typically do this by doing this antegrade through the distal phalanx and then closing the IP joint and then retrograding the K-wire in place. With a satisfactory K-wire position, then I can replace it with a cannulated for a partially threaded screw. In terms of the tendinous work with the EHL, I would extend the previous dorsal incision that I have with my dorsiflexion osteotomy a little bit distally, and then I can harvest, pull back my EHL. And then drill around the metatarsal neck with a small 400 drill, both medially and laterally, and then take my tendon, loop it from lateral to medial to kind of fix the first ray down in a slightly dorsiflex position. The lesser toes usually are not significant in terms of prominence, so I do not automatically correct them. Because patients tend to not have complaints about that. Although for very severe and a lot of high hammer toe corrections, claw toe corrections, they can certainly be corrected with flexor tendon tenotomy. So additional procedures that I don't automatically do, but I do keep in the back of my mind if needed, is I had previously mentioned the lateral column shortening, which I want to emphasize that is typically done after medial tailonnavicular release, because you're going to have tightened capsule medially that is preventing your correction from being realized. So soft tissue first, and then if that's underpowered, doing a lateral column shortening. Posterior tibial tendon can either be lengthened or transferred, and typically a transfer onto the lateral cuneiform is better. So you can see the posterior tibial tendon is being harvested on this picture, and then this incision is right over the lateral cuneiform, and the harvested posterior tibial tendon is seated into the lateral cuneiform with an interfering screw. We are redirecting the mechanical axis of the posterior tibial tendon, so it no longer acts as a very strong inverter. And then lastly, with things corrected, you want to check to see how loose the lateral ligaments are intraoperatively, because if they are loose intraoperatively, they likely will continue to be loose after your entire correction has healed. So you can address the lateral ligament laxity with a repair intraoperatively. So with this in mind, after their surgery, then I typically put them in a short leg splint for 2 to 3 weeks, and they come back for suture removal, and I cast them for 3 more weeks. By week 6, they usually come out of the cast, and I put them in a boot with partial heel down weight bearing, and they can start physical therapy to gradually advance to weight bearing in the boot. They can start to work on ankle range of motion, starting with dorsiflexion, plantar flexion. And by week 10 or 11, they're full weight bearing in the boot, working on their gait training, ankle range of motion. And by week 12, they should be out of the boot into well-supported shoes. Usually they're not back to sports activity yet until at least another month of physical therapy. So I have two, if we have enough time, I have 2 cases to present. These are 2 of my cases, and you can see some of the challenges and things that are somewhat undercorrected as well. So this is a 22-year-old woman that came in with lateral foot pain. 4 years ago, she had a very significant trauma. She fell from a cliff and had multiple polytrauma, pelvis fracture, and along with those bilateral talus fracture and calcaneus fracture. Right calcaneus fracture. But she's coming in to complain about her left foot because everything else is somewhat healed. She's now developed a very painful plantar ulcer underneath the 5th metatarsal head. And she said her foot will roll out under her. She has a hard time walking. And her pain is predominantly over the plantar aspect of the ulcer. So you can see on her AP x-ray, she has her talus fixed with the intact implant in there. And the medial column is a little bit shortened from the talus malunion. And on clinical exam, you could see that when she stands, her lateral column is bearing the majority of her weight, and her first ray is hardly touching the ground. And you can kind of get a sense of that from her lateral x-ray here as well. She has about a 4 centimeter large callus over the fifth metatarsal head that's very painful, and her eversion is weak, a 4 out of 5. She has focal tenderness also along the peroneal tendon in zone 3. She does have some subtalar joint passive range of motion on exam. And you can see that her overall alignment of the hindfoot, she does have hindfoot varus deformity as well as a high arch. So her diagnosis, she has the CavoVarus deformity predominantly from talus malunion, and now also has plantar ulceration as well. Her ankle does not have any varus deformity. So the surgical plan for her was to do first a percutaneous Achilles tendon lengthening, and then this is followed by, for me, a minimally invasive lateral calcaneal osteotomy. And with the calcaneus fixed in a better alignment, then I would focus on first metatarsal dorsiflexion osteotomy. Then I go back to strengthen her everters from tagging the peroneal longus to brevis. And intraoperatively, I examined her afterwards. She still had significant lateral ligament laxity, so a rostrum was performed. So this is her 3 weeks post-op. You can see with the calcaneal osteotomy, I shifted a little bit superiorly as well. And her overall hindfoot alignment is much straighter now. And I used a dorsal plate as well as a 9 staple to help compression across the metatarsal osteotomy. And 3 months later, she's now walking and able to run. She does not have any pain, and her ulcer, I did not do anything to address the ulcer, but just by merely offloading, and the ulcer is now gone. You can see from the lateral weight-bearing x-ray, though, that the dorsiflexion osteotomy could have been done more because the first rate is still slightly is still not slightly even. The osteotomy is now well healed. And for some people, the dorsal plate can be removed for younger patients, but this patient is happy and does not want to have any more surgery for this particular foot. Now, the second case that I picked out to present is also another young patient, but is in a slightly different in that this patient has developed substantial post-traumatic arthritis. So she's a 27-year-old polytrauma patient after MVA, and she had left calcaneus and talus fracture treated with open reduction internal fixation 2 years ago. Now she's coming back saying she has difficulty walking, her foot's rolling, and she has lateral foot pain as well. So on exam, she also has left hindfoot varus and a CavoVarus deformity. And she also has tenderness along the sinus tarsi, as well as along the talonavicular joint and the calcaneocuboid joint. This particular patient, she has very rigid hindfoot, just no motion at all in the subtalar and the transverse tarsal joints. So here again, you can see she has a very high arch. You can see overloading the lateral border of the foot, and you can also see extensive amount of arthritic changes in the hind foot, which is better visualized on CT as well. This is her Harris view of axial alignment, and her varus deformity is about 20 degrees on X-ray. So you can see she has the talus and calcaneus malunion that substantially shortened her medial column. And she also now has developed rigid CavoVarus deformity with post-traumatic arthritis in her subtalar, her talonavicular, and calcaneocuboid joint. So, and she also has equinus contracture clinically as well. So in order to address all of this, we performed an endoscopic Strayer procedure to address her equinus contracture, remove the prior hardware, and then perform a triple arthrodesis to correct the overall alignment. even with the triple arthrodesis, her first metatarsal was still plantar flex, and a first metatarsal dorsiflexion osteotomy was performed. So this is her post-op x-ray. You will see first and foremost on the right that her alignment is now straight. She has a new set of hardware and quite a lot around her first and second metatarsal. This happened because she had very osteopenic bone. And as we were doing the dorsiflexion osteotomy, she sustained an intraoperative metatarsal fracture. So in order to address the fracture, a dual plating, a medial plate was placed, and the first metatarsal was also corrected and fixed onto the base of the second metatarsal. So the patient has fused across her triple fusion, and the overall alignment is better. She's more stable. She's no longer overloading her lateral ray, and her pain has been resolved now 3 months after surgery. Okay, so those are the two different variants to address CavoVarus deformity. These are some of my resources from the talk, and I'll be happy to take any questions.
Thank you, Annie, for that excellent presentation. You've almost covered the entire gamut of CavoVarus feet reconstructions. A couple of questions. Annie, what do you think is the role for a midfoot dorsal wedge osteotomy, the one described by Japas? For example, if you have the entire medial as well as lateral elevated, do you think midfoot osteotomy is better?
I do think midfoot osteotomy is better for the deformity that you were describing, primarily because that is the center of rotation, as opposed to correcting your inversion and eversion, hindfoot and forefoot, which you're really working around the center focal problem. A midfoot osteotomy is better from a mechanical standpoint, but I'm not sure that it is necessarily better from a patient outcome standpoint, because patients after midfoot osteotomy almost always have very severe rigid foot, and because to fix the osteotomy, you have to fuse through so many hindfoot and midfoot joints that they are left with higher risk of developing adjacent joint arthritic changes.
Thank you, Annie, for that. And do you always do an electromyography before you do any reconstruction for a CavoVarus foot because of the possibility of an underlying neurological disease like Charcot-Marie-Tooth?
I do. If a patient has a known cause, like a known trauma, I don't necessarily do that. But for patients that does not have, it's something that's concerning, then I do. And I always I do a very careful exam, and I ask them about family history. I think if there's any slight suspicion, I would send them to get evaluated to rule out a neurologic workup.
Thank you, Annie, for that. And what do you think is the possibility of getting a CavoVarus feet after clubfoot? While you treat patients or kids with clubfoot, do they end up with a complication? Like, for example, while they get a relapse, do they get CavoVarus feet?
They do, and I think they're different. Club feet has, depending on different parts of the country, sometimes are caught at different stages. So it's very common to see CavoVarus deformity. But usually for these young adolescents, kids, the beauty of correcting them is that you may need to do one, calcaneal osteotomy, but the rest can really be predominantly done by soft tissue transfer, and children adapt to them very well. So you don't hardly ever need to do a significant amount of bony work for children with residual clubfoot deformities.
Thank you, Annie, for that. Just one last question before we wind up the session. What do you think is the role for an Ilizarov type of construct for managing these complex deformities?
Oh, I think anytime you have a reconstruct for correction is typically great, because then you can do a very large scale correction, but it's typically not needed unless you're changing a significant amount of length. So for instance, when you do a midfoot osteotomy, a large correction, then doing a reconstruct would be very helpful. If you're doing a supramalleolar osteotomy having with a significant amount of closing wedge length difference, then a reconstruct would be good. Realistically, to have someone with a reconstruct and to have them come back and have the medical access to come to your office every week or every other week sometimes is very challenging for patients. So I think the reconstruct is great in theory and for a certain type of population, a certain type of environment, but not every patient is perhaps ideal for that. So if I find patients that need a reconstruct, I would tell them they're at a higher risk of, surgical complications, for infections, and it's a generally on the patient's end, a much more difficult recovery process. But they can have a very good and solid, mechanical, medical, their mechanical correction.
Thank you, Annie, for that. Annie, would you mind stop sharing your screen? Actually, there's
Sure.
Actually, I forgot to tell about. Yeah, thanks. Annie, I think that's all the questions that we have for this session. Fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in, Annie.
No problem. Thank you for inviting me.